Welcome to today's presentation of another look at PCOS from a neurotransmitter perspective. The presenter who will be leading our discussion today is Dr. Allison McAllister. Dr. McAllister is the lead clinical consultant for ZRT Laboratory. She sees patients in her own practice several days a week and has worked with ZRT for over 15 years, helping hundreds of doctors understand hormone balance and the role that elements and hormones and now neurotransmitters play in overall health. In addition to working for ZRT, Dr. McAllister also regularly lectures for groups such as the A4M and PCCA at industry conferences. With that, I'll turn it over to Dr. McAllister to begin the content portion of today's webinar.
Thank you, and thank you everyone for joining me today to talk about PCOS. It's one of my favorite topics because it entwines so many different hormonal imbalances and so many different hormonal systems. And of course, it's always unfortunate when it happens to a patient, but from a biochemistry perspective, it's kind of interesting to see when things go wrong, what the cascade of problems is. I started lecturing and talking about PCOS, believe it or not, about 10 years ago, and I think some of the newest and most exciting research is actually coming out of the neurotransmitter role of PCOS, which I think is kind of funny because now, of course, we're doing neurotransmitter testing, but in fact, this research is also coming out about PCOS and then also looking at other endocrine disorders as well. So we're going to start looking at kind of the role of PCOS. And first, let's talk a little bit about what PCOS is for some people that may be new. That's polycystic ovarian syndrome. And there's our learning objectives. But PCOS is very, very common. It's estimated 4 to 10%. I've actually heard up to 20% of all women who have PCOS or women may have PCOS. It is considered treatable but not curable. But we are starting to get some information about why that is and what's causing it. So, for instance, I think it's interesting in just like the last 5 years or so, there's 3 SNPs that have been identified with insulin receptors. There's some different polymorphisms that are coming out about mitochondrial function and abnormal heat shock proteins. There's some interesting research, which I think is just starting, about anti-Müllerian hormone secretion. So we're kind of coming down to like this genetic portion, which of course is at least part of what some women's PCOS is being driven by. So I think this is a new and exciting way to start looking at it, and I think that, you know, as we start delving into the role of genetics and health, I think this is just going to become, you know, more and more interesting, but of course you can't really change it, but I think more interesting as far as getting to the cause of why we're seeing such commonality of it. In order to diagnose it, a lot of people do get confused. Basically, in order to diagnose it, you need to have symptoms of high androgens, and you need to have high androgens on lab testing. You do not need to have an ultrasound. So some people think, oh, you have to, but in fact, no cysts need to be seen on ultrasound, but they are usually seen. And there's multiple different phenotypes of what PCOS looks like. So what I find is that there's basically, in my world, 2 commonly seen variants. There's one group of women that just have the ovarian portion of polycystic ovarian syndrome. They tend to be leaner. They have less insulin resistance. They tend to often present only upon trying to get pregnant and having problems. And they tend to have higher testosterone, but not DHEA. The other portion is what I refer to as ovarian and adrenal. They tend to have much more obesity, be much higher in their insulins and hyperinsulinemic. They can have but they can have regular cycles, or they have no cycles whatsoever. And they tend to have both high DHEA and high testosterone. As far as like the leaner goes and the obesity, many people get ruled out of having PCOS because they're not obese, or at least overweight. But 40% of women will actually be lean. with PCOS. Now, you have to often ask the question of how do you stay lean, and sometimes you'll find out, they're only eating 500 calories and running 5 miles a day, and that's, not crazy to see for PCOS women that that's what it takes in order to control their blood sugar and to control their body weight. But this is kind of the two looks, and there's lots of different ways that people sort of break that group out, but basically they break into that. Signs and symptoms that you might see, obviously obesity is one of them. You have to consider it with that. Acne, increased facial body hair, few periods, no periods, infertility, family history of polycystic ovarian syndrome, but also family history of diabetes. Acanthosis, which is the yellowing of the pigment of the skin, usually seen around the neckline or under the armpits. Type 2 diabetes, and obviously family history of that. Endometrial hyperplasia is not as common, but it does still happen. Menorrhagia, hypertension, and reactive hypoglycemia. In fact, a lot of times these patients will say, I get hypoglycemic, and they're maybe 200 pounds, 100 pounds overweight, and you're like, what? And really it's the high insulin that you're seeing there. As far as family history, a lot of people say, well, a lot of my patients with PCOS don't have a family history of PCOS, and that is true. A lot of times you have to dig deeply with family history. A lot of women nowadays are delaying childbirth until their 30s and 40s, and that's actually the time that a lot of PCOS women have the hardest time getting pregnant is in their 30s. They tend to have an easier time in their teens and early 20s, and they tend to have an easier time oftentimes in their late 30s and 40s, even in getting pregnant. Whereas historically, a lot of women were having their children in their early 20s. Their mom, who may have PCOS, when they had their babies when they were 20, by 23 she was done with her family. She never really saw some of the impact of it. So you have to ask about the increased family facial body hair or acne, etc. And patients throughout their lifespan will have these symptoms at varying degrees and varying problems. So a lot of times you'll see a normal weight child all of a sudden develop terrible acne in their early, late teens, and then the acne gets better. And then all of a sudden they have weight issues, and then the weight kind of stabilizes, and then all of a sudden they're getting more facial body hair, and then that kind of stabilizes, and then they get a lot of loss of scalp hair. So their symptoms don't always present all at one time. They can kind of take turns, and you shouldn't rule that out as far as PCOS goes. So when we look at the ovary, this is obviously the ovary doing everything that it does all at one time. One of the things that we see is that with PCOS, that the follicles are kind of stuck in this primary follicle phase. So they seem to be sort of stuck in hibernation mode, and they don't go on to develop into basically mature follicles and then releasing the eggs and then developing the corpus luteum. So that when you get a PCOS ovary, it basically is filled with lots of these cysts instead of just one, and lots of different eggs. And that's, multiple different factors involved, but one of them seems to be that the egg, even when it develops, doesn't actually ovulate. And so you get these sort of different thick-walled cysts and this thick-walled uterus or ovary, so that if you're an OBGYN surgeon, they will tell me, like, they can almost feel the ovaries and actually know that they are cystic even without looking at the cyst, just by the feel of the thickness of that lining there. So with the high insulin that you see with PCOS, which you do see high insulins, you actually have increase in IGF-1 levels, adiponectin is impacted, sex hormone binding globulin, lipids, clotting, and then alterations in liver, muscles, ovaries, etc. So let's talk a little bit about what's happening in the hormonal picture. So this is sort of normal ovarian production. The thecal cells there are making testosterone, and they make estradiol and DHT, and that's normal from the granulosa cells. But in PCOS women, they are thought to have a decrease in aromatase activity, so that within the ovary itself, and that's all we're talking about here, they actually make lower amounts of estrogen, and as a result, they pump their testosterone up to try to keep their estrogen levels increased. So in general, they have this lower estrogen in the ovary, making higher androgens, and then because they have higher androgens, they also tend to have a system where they have a lot more 5-alpha reductase enzyme, and so as a result, they make a lot more DHT from that testosterone. So we end up with a situation of high DHT and low estrogen within the ovary. Now, we're going to bring on the adrenal glands. So the adrenal glands also have a P450 system. So if we look here, I'm just going to use my little monitor. I think they see it. So this P450 system here is going ahead and making DHEA. That's normal. That's what we want to see happen. And that's also making testosterone, which then makes DHT because of higher 5-alpha reductase, but also makes a higher estradiol out here in the system. And when we're looking at the adrenal glands and the rest of the tissue, we also end up with higher aromatase in the periphery than there is in the ovary. So we end up with a lot more estradiol, a lot more DHT, and then we've got a lot more DHEA. Now, this gets more complicated. So LH is driving that system. We also have the adrenals producing cortisol, and we have increase in 5-alpha reductase in the cortisol metabolism and 11-beta hydroxysteroid dehydrogenase, always a useful term for Scrabble. And so what we have is a hole in the cortisol bucket where we're dumping our cortisol and actually producing a lower amount of, or a higher amount of cortisone. So we're inactivating our cortisol as we turn it into cortisone, which is inactivating it. But unfortunately, the feedback back to the brain to produce ACTH is actually made by cortisol. So as the cortisol becomes inactivated into cortisone, the brain turns up the signal to make more cortisol. However, in body fat, you can take that cortisone and turn it back into cortisol. And so a lot of PCOS women will have a look that's much more Cushingoid than it is Addison's, because they have basically in circulation body fat being exposed to high amounts of cortisol. But in like salivary testing, et cetera, you might see actually normal to low cortisol levels, but say in urine testing, you might see that higher cortisone level as well because of that increased peripheral circulation. So we end up with this drive. Now, high ACTH is driving that cortisol, but what else is it going to drive? It drives DHEA, which does not feed back onto ACTH. So we just keep pushing these androgens higher and higher and higher. If we add insulin to this picture, it actually stimulates LH directly and the 11-beta hydroxysteroid dehydrogenase. So we're even channeling that even further and pushing those levels up. Now, when we look at hormones and we look at estradiol and progesterone, they themselves are basically neurotransmitters. They have neuroprotectant effects, anti-inflammatory, antioxidants, regulating all these different things within the brain, and they definitely have interactions with serotonin, norepinephrine, progesterone, and GABA. And this is where some of the new research with PCOS is going, because we know they have some imbalances within the ovary and body fat with estrogen, progesterone, and GABA in general, or estrogen, progesterone in particular, estradiol within the ovary tending to be low, but in body tissue tending to be high, and then progesterone tending to be low because of the lack of ovulation. So let's look at some of this new research that's coming out about neurotransmitters and polycystic ovarian syndrome. So it's actually found that 60% of women with PCOS have mental health issues. And this has actually been really interesting. They've actually done studies where they've polled women with PCOS and found that they had less quality of life than oftentimes cancer patients do. And I don't think, knowing my fabulous PCOS patients, that many of them are sitting around being unhappy that they have increased facial body hair or they don't have their periods. And one theory that for a long time that's been going on is that they have altered receptor statuses. And I think that that's probably true. But there's some new information coming out about this as well. And one theory is due to basically the in utero environment, so that when that young woman was in utero, and I have to question whether it's actually even her mother was in utero. I think it probably, the impact could be seen multi-generational. But one theory is that when she was in utero, that there was high testosterone, and that there was also increased anxiety, and that created changes to her brain that changed her estrogen receptors and her androgen receptors, and changed genes regulating serotonin and GABA, basically preparing her for a very stressful life outside of the womb. So if we look at norepinephrine, this is basically our neurotransmitter that is reflective of the sympathetic nervous system. It has impact in the locus coeruleus, the sympathetic ganglia, the adrenals. And in the brain, the norepinephrine pathways and the serotonin pathways, you can see, are basically duplicates running throughout the entire brain and cortex of the brain very, very quickly. It's related to fight or flight, so this is increased respiration and skeletal muscle. You got to run away from that tiger, right? Drive that blood sugar up, increase that blood pressure. You've got to get away. Well, it's been found that women with PCOS are running higher norepinephrine levels in general than their peers, even at the same stress response. So they have higher muscle sympathetic nervous activity, they have altered heart rate variability, their heart rate after exercise tends to be higher, and this drive of this increased sympathetic nervous system activity is running havoc with pretty much every metabolic pathway. So treatment-wise, to lower it, weight loss will help, but of course it's harder to lose weight when you're running away from tigers all the time. They've experimented with low-frequency electroacupuncture. Obstructive sleep apnea and treating obstructive sleep apnea has been found to be helpful, which is higher in PCOS women. And renal denervization. Now, I think this is really fascinating. So what that is, just for people who don't know, because it's really fascinating, was they take people who have malignant hypertension and they go ahead and they cauterize the sympathetic nerves to the kidneys. So they're trying to basically treat people's hypertension who they can't control with medication. And what they found was that decreased the sympathetic drive of the body. It actually cured some patients' insulin resistance, which I just think is kind of crazy because we just don't think of that. But I think what that tells us is how potent having high stress all the time in our lives contributes to everything, contributes to the insulin resistance and the whole picture. So right now what we're finding is there's maybe this pathological condition, genetics, etc., that you have this increased sympathetic activity. What that does is it drives the sympathetic flow to the ovaries, and it increases nerve growth factors within the ovaries. It's also stimulating a lot of adrenal dysfunction, and then of course you get pathology. So I think PCOS is very poorly named, is really what we're coming down to, is that the ovaries are just one way that you see all this impact of things like altered androgens and altered sympathetic nervous system activities, but they are just a sign. And in fact, we know that you can remove someone's ovaries and they still have PCOS. And so I think that this also is why we're seeing partially so much more PCOS. So like not only do we have more insulin resistance, but I think that insulin resistance is also coming along with a lot of people with a lot more stress all the time. Could this also be why people go on vacations and actually get pregnant for those people who have infertility? Yes, perhaps. To low levels, this may be a factor for a lot of women, stress and not ovulating regularly, and I think that's pretty common. But definitely for polycystic ovarian syndrome, it seems to be kind of one of the things driving the show these days. So estradiol and norepinephrine are kind of entwined here, and you can see just metabolism of norepinephrine converting down through COMT, which is also metabolizing estrogen. So we have lots of different factors here entwining and increasing and decreasing receptors and release. If we look at this insulin resistance, it's also being driven by the sympathetic activity. So we see people who have muscular sympathetic nerve activity having higher sympathetic nervous system activity, having impaired catecholamine signaling. Those are your epinephrine, norepinephrine, dopamine. Your higher adipose tissue is driving that as well, but is also being contributed and caused by that. Leptin resistance is part of this, and then high insulin as well is also driving this. So you just end up with everything's making everything worse. And norepinephrine, dopamine, and serotonin are three of the biggest transmitters that are associated with mood. And one of the things that we also know with PCOS is getting these neurotransmitters into the cells seems to be difficult. They have a hard time getting their neurotransmitters into the cells, and we've kind of known that for a long time. I've been lecturing about that for a long time, but I think now to know that you also have altered amounts of things makes things even worse. You know, you can't get into the cells and you don't have the right kind of things. And we found that there's all sorts of neurotransmitter receptors that are altered, like dopamine receptors, like GABA receptors, and NMDA receptors. And what they do is they change the pulse of gonadotropin releasing hormone so that you're not getting those nice clean LH and FH surges on a daily basis, which actually drive ovulation. So these neurotransmitters and their alteredness seem to be driving not only how you feel, but may also be altering the pattern of ovulation within these individuals as well. And they're being linked to the combination of the catecholamines and the high testosterone in releasing more from adipocytes, producing more free fatty acids, which then alter insulin signaling, HPA axis. Once again, sympathetic activation is disturbed and more insulin resistant. So we're really like not getting that feedback with insulin and driving that sympathetic nervous system by having more body fat, but they themselves are driving more body fat. So we could have arrows going all over this pathway of what's causing what, but basically it's a big, huge snowball going downhill faster and faster. So GABA is one of the brakes on the system of the sympathetic nervous system, and I don't know how many people are using it. Most people use it for anxiety, but GABA is not just used for anxiety. So this was actually a really interesting article for diabetes using GABA, and what they found is that GABA is produced by islet cells to regulate islet cell secretion and function, exerting beta cell regenerative effects and protecting against apoptosis, anti-inflammatory, and immunoregulatory. In summary, basically what they found was that GABA keeps your beta islet cells around and prevents them from degrading, which protects you from long-term diabetes. Very, very profound to know that this neurotransmitter can have such an impact on such a common condition. So GABA, I think we're going to start seeing more and more in diabetic products, and you have to remember that patients with PCOS are pre-diabetic. So GABA regulates catecholamine release, and in the GABA receptor, here's a little GABA receptor here on the adrenal glands, and it's controlling the release of norepinephrine and epinephrine. So that when we have really high levels, basically GABA slows it down so we aren't producing tons and tons of norepi and epi, and it's actually feeding the system so that we can actually not end up burning ourselves out. So it's actually upgrading how you absorb tyrosine so that you can continue making high levels of norepi and epi appropriately. So GABA is one that we're going to actually start thinking more and more of in terms of this. So high insulin is really the picture that we're talking about, and all these things are driving that. And I often have people say, well, their hemoglobin A1C is normal, but that's not what we're talking about with PCOS. We're talking about insulin. And what we see for patients who have PCOS is that their insulin, and that's this red triangle down here, stays higher and goes higher after meals. Usually you could see it in 1 hour or 2 hours after a meal. In general, your fasting insulin should go no more than 5 times higher than your fasting level. So if your fasting level is, say, a 6, it should not go higher than a 30. And I have seen patients with PCOS start with a fasting insulin level of 5 and have a postprandial 2 hour after a glucose drink insulin level of over 200. So they produce a huge amount of insulin, similar to type 2, but continue to control their blood sugars. So their glucose is normal, but their insulins are high. Now, to control that, we definitely are talking about neurotransmitters to control that and other things, but this is another thing that we can do that helps control insulin resistance. And this is a fascinating new research that's coming out about myokines. So myokines are like cytokines, but they're actually produced from the muscle. And this is actually the benefit, right here what you're looking at is basically the benefits of weightlifting and how it increases glucose and how it alters these myokines. And there's some really interesting research coming out. I think this is kind of where PCOS is also going into the role of these myokines also being driven by the sympathetic nervous system, but how you can reverse that by weightlifting and all the things that weightlifting can do to basically help restore and improve that post-insulin surge. So a lot of times when you have patients who say, I'm hypoglycemic, I honestly look at them, and if they are not, kind of normal to underweight, I would be very suspicious that they, in fact, are not hypoglycemic, but are, in fact, hyperinsulinemic, and it will feel very much the same to them. So assessing the patients with PCOS, you definitely want to do your sex hormones. You want to rule out thyroid. They have a lot of association thyroid. You want to think about doing fasting insulin, glucose, but definitely also think about a 2-hour postprandial. You often will only see the higher insulins at that time. A 17-alpha hydroxyprogesterone, a lot of patients, that's congenital adrenal hyperplasia marker, not very common, but will look just like PCOS, so you don't want to miss it. CBC, prolactin, LH-FSH, CRP, these are just sort of your standards. And then I think now you could kind of argue that you should be doing a norepinephrine screening as well. And your treatment is to lower your androgens, to increase the sex hormone binding globulin because that lowers your androgens, to normalize that insulin resistance, and to lower the sympathetic nervous system tone. You really want to drop that tone because that's driving everything else to be worse. And to optimize hormones, of course. Okay. So lifestyle support, relaxation, or a little pet therapy, I should say. Weightlifting, because of myokines, there's some research that's there. I think you want to be happy and play and choose good eating. And happy and play is because, of course, that will lower your sympathetic nervous system tone as well. So conventional medicines, we have oral, we have spironolactone, we have metformin, Clomid, letrozole. Obviously a lot of talk with PCOS is often around fertility, and that's because a lot of times that's when patients will come to you. They will come to you because they want to get pregnant and they're having problems. I think it's important to just take a note here. I'm a naturopathic physician. Obviously, I love naturopathic medicine. I offer my patients with PCOS everything. And I think it's important to, when you're dealing with a condition that's treatable but not curable, I try to take my ideology out of it and look at that patient and offer them everything that I have. And that includes both the natural things and the conventional medicine. And although I don't love all of the things like, say, birth control pills, I don't love all the things that go along with that and risk factors, and I might not want someone ideally on it for 30 years. Sometimes a 17-year-old girl who's got terrible acne and whose self-esteem is in the toilet, I might choose it for her at that time, or I might suggest it, or I might just empower her that it's okay for right now, even though she also doesn't want to do it long term. So oral contraceptive-wise, for instance, you want to choose one that's higher estrogenic, high progesterone, low androgens. Yasmin, Yaz was really designed for this program. It was really kind of built for PCOS women. And there are some benefits long-term of being on birth control. It does regulate skin and hair issues. It often takes about 3 to 6 months to see that. It can regulate cycles, make them more predictable, which for a lot of PCOS women is pretty helpful. It increases the sex hormone binding globulin, and even after someone stops them, that actually can continue for up to a year. The other thing that it can do is it can help weight. A lot of women with PCOS will actually lose weight on birth control pills and gain weight once they come off. And I think that's because they're in a higher estrogenic position and lower androgens, and there's some research that those androgens, like I said, with the catecholamines, can potentially drive the insulin train, and so by jumping off that testosterone, perhaps that's decreasing it. But a lot of my PCOS patients will actually gain 20 or 30 pounds coming off of contraceptives. I also think it's important to note here that if women are trying to get pregnant, there's sort of a, I think, sort of natural thing of like, oh, I want to come off of birth control pills, and, you know, I want to get my body back to natural state before I get pregnant. No, not for PCOS. You basically say come off of it and try to get pregnant right away, because every month that comes on after they've stopped the birth control pills, it'll actually be harder and harder for them to get pregnant. So this idea of like you want to restore natural there, no, not with PCOS. You basically keep them on it until they're ready to get pregnant, and then they try to get pregnant basically the first couple months after it, because it's harder and harder for them. Risks, it may worsen insulin sensitivity. However, I don't see that as being significant, but it is sort of this known risk. And for PCOS women, I think they have a lot to gain from it. And like I said, I think teenagers and self-esteem, that's actually a time where I've used it the most for PCOS, is just because the acne can be really hard for people. But for patients who don't maybe have acne, hair loss, don't want to do birth control pills, spironolactone is an option. BOPS 5-alpha reductase, so it decreases those androgen effects. There's, you know, lots of drug interactions that you have to worry about, but in general, it's pretty well tolerated, 40% improvement in 6 months. Metformin, a lot of people are curious if they should be doing metformin if they are a thin patient with PCOS. The research actually suggests yes, they still have benefit. So I put a little thing as to what it does. You know, side effect wise, you know, you can compound products to get around from it. When I was just at PCCA lecturing, there was a woman there who was fabulous, and she was saying that she works with a lot of fertility clinics, and they're actually doing metformin vaginally, which I thought was really interesting. You know, just not something that you kind of normally see. So they were using like 5-10 milligrams actually vaginally to sort of go directly to the ovary. So if you're interested about that, you have to reach out to PCCA and maybe find out exactly what dosage or how they're doing it. But I don't think they were doing anything super special. They were just using it that way. But yeah, people have used it topically for quite a while now, avoiding gut effects. However, the gut effects are part of how it works. So decreasing carbohydrate absorption, I don't think you're going to get that if you're using it topically, although you will still get the gluconeogenesis inhibition if you use it topically as well. Protecting the beta cells again, but really what it does is it reduces that insulin and improving cardiovascular health. And you have to remember that once again, we could remove the ovary and these women still have PCOS. It's very poorly named at this point. We could call it hyperinsulinemic disease. I think there's lots of different conditions that we could sort of rename it. But you know, basically you remove the ovaries and that's just part of the problem. So even after fertility is an issue, these women have a high rate of endometrial proliferation and thickness, and also have higher rates of cardiovascular disease. So with women who are pregnant, though, it's actually more research coming out about using metformin throughout pregnancy in the first trimester to prevent miscarriages, and in the second and third trimester to actually improve lactation. So high insulin actually reduces your ability to breastfeed. And there's some research coming out about that as well. So glucocorticoids, now why would you use glucocorticoids in someone who already has higher cortisols? Well, they don't have high cortisols. They have high cortisone relative to their cortisol, but it's mostly because you take the adrenals out of the picture. So you control the cortisol and you don't let the ACTH drive the DHEA up. Samuel Thatcher, whose book is at the end of this presentation I mentioned, has a protocol of using prednisone almost, all the time with his fertility patients, but also for his PCOS patients as well. So it's kind of an idea. I put everything out there for people. There are so many natural products, however, to consider, so we're going to just talk about a few of them. Insulin-resisting-wise, chromium, gymnema, berberine, and inositol. Berberine has similar effects to metformin. All the action is on there. Remember, you want to do an activated or a concentrated extract, I should say, of berberine. It's going to be much more effective. You're going to have to take a lot less pills. So I put the rough dosage on there, but you're going to find some products that recommend less, and it's just because it's more concentrated. Berberine still can have GI effects for women as well, partially because of how it's working. And it does have this action of also being an antibiotic, which, I think is kind of an interesting question, but may actually be why berberine is working for some women with PCOS is, dysbiosis. Dysbiosis will also sort of drive this train. So what's the cause? What's the effect? For some women, berberine might work better if they have that dysbiotic syndrome as well. For other women, metformin will, but some sort of glucose monitoring would be good. Now, I wish I owned the company that made inositol, wherever it is. I love inositol. I think this, from the research that I've done, besides this whole now, multi-generational sympathetic nervous system drive in utero, which, you can't really do anything about, the research on inositol and inositol signaling to get things into the cells is really powerful. So inositol works for almost every receptor site. I was actually going to do this presentation once on all the receptors that inositol works with, and then I found it was like over 200, so that was the end of that presentation idea. But inositol works on almost everything to open cells and get those neurotransmitters, those serotonin, that insulin, that estrogen into the cells. So very powerful, very easy to do, does not fix anything. In other words, you only get the effect as long as you take it, but very easy to take, relatively inexpensive. Research has happened on myo-inositol and also D-chiro. Myo-inositol is the most regular inositol that you see. D-chiro is much more expensive. So I don't see any reason to, frankly, do myo-inositol first and D-chiro if it doesn't work. It's actually been associated with good follicle quality, so I use it in women who are trying to get pregnant anyways, but and throughout the entire pregnancy. There are tons of studies coming out about using inositol in prediabetes, not in PCOS women, but just diabetes and prediabetes. So anyone who has insulin resistance, it's worth looking at this. So easy to do, tastes sweet, 2 grams. I would say at least twice a day is really the recommended dosage that I use, which is 4 grams a day. That sounds like a lot. It's 1.5 teaspoons, so it's really easy to do. So I've done tons of studies on it. With metformin, it's fine. With berberine, it's fine. Much higher pregnancy rates. You can do it with patients who are doing Clomid or Letrozole. Very effective, and I make it as part of all of my PCOS, but also part of my fertility profile as well. So lots of studies on regular periods and gestational diabetes, so it's totally safe in pregnancy. You can get it from foods, you just have to eat a lot of them, so it's not really as effective, I don't think. Saw palmetto can be really helpful. 350 is the minimum. It's actually often at times I'll use up to 700 milligrams per day of saw palmetto. And some women have to take that like 350 twice a day so that they're getting continual levels every 12 hours around the clock. Some women have gone as high as, like I said, 700 milligrams twice a day. Decreasing DHT and reducing the androgen load that way. NAC is great. 1,500 milligrams usually per day, 1.8. I usually start lower and work up. It is a detox as well, so you have to be aware of that. But it can really help with the insulin sensitivity. The research has really shown that it's only helped the hyperinsulinemic patients, but it can help with Clomid. And in general, I find it's a really good liver detox. Also thins mucus, so it's kind of a benefit. That's why a lot of times it's used in fertility. But it's easy to do. You can take it with food, which is what I recommend, because it sometimes can cause reflux. I've seen some pretty bad reflux. As far as adrenal support with PCOS patients, you kind of have 2 goals. We want to support appropriate cortisol levels, so we want to stop that conversion from cortisol to cortisone, but we also want to lower the sympathetic overdrive that's just going too much. So we want to try to reduce that ACTH drive. Why? Not only because it'll reduce the cortisol and this kind of Cushingoid appearance that women can have, especially that increased belly fat, but we also want to reduce that DHEA levels as well. So licorice is my favorite for this. Remember, it can increase blood pressure. It takes about a week if you do that for people's blood pressure to come back to normal. Ask me how I know. Yep, exactly. So licorice is really good. It really maintains cortisol's half-life. I would think of it as the SSRI of cortisol. So it reduces that ACTH feedback. Remember, it can increase blood pressure, and it also has some anti-androgen properties as well. Progesterone, you certainly can use it. It's great. It's aromatase, has some aromatase inhibition. It's a competitor of 5-alpha reductase, so you can help lower some androgenic effect as well, opposing those estrogen dominants. For women who are having really irregular periods, it is important that you're not getting endometrial proliferation. So doing some progesterone can be helpful, but just remember, if someone's trying to get pregnant, it's not about giving them progesterone, it's about them making their own progesterone. So make sure if you're working with someone who's trying to get pregnant that you're not just giving progesterone, but in fact helping them ovulate so they make their own progesterone as well, and then you're bumping them up maybe with some added supplementation. Sorry, I'm trying to give you a lot of information in a short amount of time. Maitake mushroom. I love the mushrooms for all the immune supports, but interestingly, there have been some studies that have looked at maitake versus clomid for fertility, and basically the combination, most women ovulated. Not normally what we think, but I think the role of maitake and probably all the mushrooms for insulin sensitivity is probably just needs to be looked at a lot more. Calcium and vitamin D, there was a really interesting study where all they did was replace like 400 IUs of vitamin D, so ridiculously low level, to a group of women who had actually failed IVF, and most of them got pregnant. Hasn't been repeated. Never know why studies don't go anywhere further. But it was pretty profound because they weren't even looking to see whether they got better. Like they weren't even looking to see if they got optimal vitamin D levels. So the role of vitamin D as a hormone, but also as dealing with the insulin resistance, I think is really powerful. For ovulation, of course, that's going to help. If you ovulate, you don't make as much androgens. It's going to help PCOS as well. So you want to dose your vitamin D to correct that deficiency. And so, doing some cod liver oil or doing vitamin D capsules or drops is going to work really well for restoring that as well. So my absolute for PCOS is that they follow a lifestyle that's generally lower carb to control that insulin, higher protein, that they sleep. I think this is where this high sympathetic nervous system drive is really important, and the timing of when we produce high cortisols, when we produce high norepinephrine, doing that at nighttime is not good. So having some lifestyle tricks around bedtime and making sure that they're relaxing and calming and that their nighttime is a time with less stress, so treating sleep apnea, trying to get them into deep sleep, I think is really important to try to reset that sympathetic nervous system. Doing inositol. I think that the research on PCOS and inositol is so strong as to be almost causal that I think that is really important to do. That people use either a berberine or metformin, and I say that for both in the thin PCOS women or the more heavy-set PCOS women who have more clear insulin resistance. The studies really show that even thinner women with benefit. Some sort of adrenal support with licorice, remember the hypertension, but some sort of adrenal adaptogen, trying to control that cortisol and also inhibit that cortisol to cortisone production. And then I think stress response, dealing with stress is extremely important. These are a couple resources that I think are good. The PCOS, the Hidden Epidemic by Samuel Thatcher is a little out of date at this point. However, it's not because, of course, physiology hasn't changed. So it's still pretty helpful. And I think that the resources there, especially how PCOS, the ovary works with PCOS, is extremely helpful. And I think that can be really helpful to look at. And then if you have any other questions, hopefully people have asked them here. We're just going to have a look here and see what questions people have. And I can go ahead and kind of read through. So how can we define, okay, so people talked about estradiol having anti-inflammatory effect, And yes, estrogen does. Estrogen actually reduces interleukin-6 and interleukin-12. So that definitely is an effect. In fact, menopausal women, joint pain is actually one of the biggest symptoms, and it's also why your breast cancer patients have a lot of joint pain when they're put on anti-estrogen. So that is definitely true. And so women with PCOS have this really mixed picture. Within the ovary, they tend to be lower estrogens. Within the body tissue, they tend to be higher estrogen. So they really kind of have this mixed picture, but inflammation does seem to be part of the picture of PCOS, and it's probably mostly driven by insulin resistance. So patients with what ZRT tests should you do with patients with PCOS? Our hormone profile 3, which has the sex hormones, the adrenal hormones, and the thyroid hormones, it's a combination of blood spot and saliva, is probably one of my favorites to start with. You can use the blood spot with that profile. It's a TSH, T4, T3, TPO. You can also add an insulin to that, and a lot of times what I like to do is actually have my patients do some sort of meal. You can do the jelly bean meal, you could do International House of Pancake meal with a high insulin, and you could do a 2-hour postprandial for that, and you can get a lot of information if you did that with blood spot. I've actually used the blood spots with a glucometer in combination to actually, you have to do 4 blood spots, by the way, but I've had people do that as a way to do sort of a less inexpensive glucose insulin challenge test. So they go ahead and do the glucometer and then collect insulins, and then we get the insulin results from the blood spot. So that's another option. I know I'm talking fast and people are going to get frustrated, but if you have questions, my email's there. 5-HTP, I didn't actually say, if someone has, what did I say about it? I actually didn't mention 5-HTP. The research with serotonin, I think, is definitely, these neurotransmitters are not working right with PCOS. There's less research on serotonin, although it doesn't seem to be getting into the cells, and I think that's really what it comes down to, is the inositol. But the norepinephrine is where a lot of the research has come basically as a driver of the sympathetic nervous system. So drug interactions with metformin, there are, but they're pretty few. It is okay to take berberine and metformin together. You may get more GI effects with doing the two together, but it's not terrible. So that's something you could consider, but I would probably not do that right off the bat. I would start with one, and then if you wanted to add a second one, you could certainly do the second one. Is Vitex helpful for PCOS? Vitex can be helpful, but Vitex works mostly by LH and FSH and trying to correct that, also prolactin. So it has limited uses in PCOS. It doesn't tend to be as useful as basically I want it to be. So you can try it, but a lot of times women with PCOS will have this high LH level. Some women with PCOS will actually, on their ovulation predictor kits that look for the LH surge, will actually have a positive every month of the cycle because they run such high LH levels. So about 50% of patients can do that. So Vitex can be helpful, but it's not as powerful as it is, say, the young women who's just not having cycles. So you can always try it, but it just may not be as powerful. I have a question. Can we use honey or other foods for glucose tolerance tests? For sure. You can do the glucose drink. You can do, like I said, the International House of Pancakes. There's recipes for how many jelly beans of jelly bellies and all the different kinds that you have to do. So, that's definitely, there's lots of different ways to do it. As far as the neurotransmitter tests go, you want to look at the norepinephrine, and I think from looking at the norepinephrine that we do with the diurnal, I think the combination of the diurnal norepinephrine and the diurnal cortisol is really powerful for PCOS. I wish I had a couple examples here. We don't have as many sort of known PCOS patients, but it would not be surprising at all to see really high norepi and cortisol at nighttime, which is really sets people up for weight gain. When your body's supposed to be relaxing and healing. Someone mentioned something about their patients having a lot of joint pain with their PCOS. That could be why, because of the sympathetic nervous system. Joint pain isn't common, but it is if you're, 100 pounds overweight. So, some of this is how much is PCOS, how much is the insulin, how much is the inflammatory markers. There's so many supplements we could be talking about. We could be talking about curcumin. There's combinations of all these products that you can put together. So there's lots of different products that are putting GABA with inositol together. Hi, Bob. So that, you can find lots of different combinations. So your patients don't have to be taking a gazillion products out there. And in fact, products are great, but it really comes down to diet and lifestyle. And I think what, if anything, this presentation should stress to you is how much our lifestyle of overstress may be why we're seeing more and more PCOS in young women. Perhaps some of this rise of PCOS is not just because of our high-carb diet, but also because our stress levels are getting higher and higher. Someone asked about the insulin or mitochondria SNPs and can we get around those? I don't know. That research is they just identified these SNPs. So I think that we're going to have to wait and see, but I think that's the hope. I think that's the hope that we're going to find some sort of magical workaround like MTHF and see some difference with that. A couple people have asked about the postprandial test. So, one of the questions is, do you need to do a 50 gram or 75? Does it always have to be there? Honestly, that's actually a really interesting question when it comes to insulin and glucose, because of course I have tons of patients who are saying, I never eat that way. Like I never eat 50 grams of sugar. And the answer is, of course, some people do, some people don't, although I have to say it's very easy to get 50 grams of carbohydrate, really, if you look at how a lot of people are basically eating. So you can certainly use the glucola drinks, but like I said, I've had people do this test with just their normal breakfast. But it will be different if they choose their normal breakfast to be sort of the scrambled eggs and bacon versus their normal breakfast of, say, Cocoa Cheerio puffs of some sort with some Dr. Pepper. Like those are going to be kind of different breakfasts, and so you're going to get different challenges. So be consistent, I think, is the biggest thing, so that you can repeat it again and again. I had a patient, here's a question, a good one about patients becoming dependent on GABA and having mood changes if they come off of it. Well, sure, they can. It's not that they're becoming dependent on the GABA, it's just that the GABA is helping control their catecholamine production. So it's making them control their dopamine, or not their dopamine, it is, but their epinephrine and norepinephrine. So it's helping them regulate this fight or flight. And if they're not fixing the lifestyle stuff, then they're going to come off of the GABA and they're going to be right back in there. And so some people might find that GABA is really profound. In fact, having a talk with Kate, who works with a lot of our neurotransmitters and are actually main scientists for that, this whole idea of like, do you need GABA to get absorbed into the brain? The answer is no. It actually has really profound action just right at the adrenal site. So it can definitely help reduce anxiety in that level as well. A question as to whether checking TPO for antibodies. Most of the time TPO is going to be the one. It's actually Hashimoto's is associated. They have a higher rate with PCOS than you see sort of with the average bear. So generally TPO is actually just fine. The thyroglobulin you can certainly test, but it will tend to be positive if TPO is positive and tend not to be positive if the TPO is negative. So, you'll just definitely do it. So once again, someone asked about the insulin glucose challenge. I hope more people are doing that test. You really find a lot of help with patients who are overweight, struggling with weight, but someone questioned about like what's a normal response. Some people have different strict rules, but you're looking basically to keep it under 40. And like I said, I've seen patients with PCOS who have had an insulin level of 5 who go to an insulin level of 200 postprandially, which is just a huge amount of insulin. Now, they never eat that way. That was with the glucose challenge, and they never eat that way because they feel so terrible. But it is kind of a common scenario. So just as a reminder, this slide presentation, because I know I provided a lot of information very, very quickly, because I, frankly, am an overeducator. Don't worry about it. It will be on the archive, so you will be able to see it in about a week or so. So you can go through these as many times as you need. There's so much more that I can't talk about, or I didn't talk about. Someone asked about heavy metals and melatonin, and those all have roles with PCOS. But in this presentation, I really wanted to really focus on, this new research that's coming out, because it really is. It's the last couple of years on the norepinephrine and I think the GABA, and I think it's a new, exciting way to look in. And if you haven't done that, like I said, I think that our neurotransmitter test with the diurnal norepinephrine and then the urinary cortisone, because it will look at that, I think has some really interesting insight for PCOS patients that I think is going to help us treat them better, and maybe not even treat them better, but maybe kind of improve compliance. That's half the battle, isn't it? Like when you're dealing with patients, you're just trying to get them to do what you want them to do, which is going to help them. And, part of our hardest thing is reducing our stress. And if you can show people, hey, this is what your stress is doing to you. Your stress really is part of this PCOS picture. I think that's really powerful for people, and really we can help a lot more of these patients. Unfortunately, these questions, these patients and these questions that we have about how to help them is just getting more prevalent. So I think we have to be aware that this can start very young. 10-year-olds can have PCOS, but you can also have an 80-year-old who actually was PCOS and has never been identified. So look for it. Help these people, and hopefully some of this information will give you another pathway to those patients that you maybe have tried a lot of other things for. So thank you very much. If you have other questions, don't hesitate to email. And like I said, it will be available on the archive, so you can listen to it as many times as you need to and catch any errors I've made and let me know. And hopefully we can have some good discussions about it. Thank you so much, you guys.